Hi everyone. Today we are going to discuss about the topic epilepsy. So, before moving into the chapter epilepsy, we need to know what a seizure is. So, seizure is defined as a paroxysmal event, which is a sudden attack characterized by the abnormal, excessive, large number of neurons firing together. There is hypersynchronous discharge of the cortical neuron activity. This may affect the muscle control and movement, our speech, vision and eye movements, awareness, and the behavior. And coming to epilepsy, epilepsy is defined as a recurrent seizure disorder characterized by abnormal electrical discharge, that is, repeatedly two or more seizures coming together from the brain, often in the cerebral cortex. Epilepsy is a chronic seizure disorder with recurrent and unprovoked seizures. So, the neurological disorder that makes people susceptible to the seizures, it is sometimes also called as a seizure disorder. It can be developed at any age. Seizures can often happen without a known cause. Many people with this epilepsy experience one or more type of seizures. The International League Against the Epilepsy, that is ILAE, in 2017 has recommended that epilepsy can be diagnosed when any of the following conditions exist, that is, a history of two unprovoked seizures at least 24 hours apart, note down at least 24 hours apart, or unprovoked seizure when the risk for a subsequent seizure is greater than 60% after two unprovoked seizures over the subsequent 10 years, or the seizures that are a part of an epilepsy syndrome. The site of origin abnormal neuron firing determines the symptoms that occurs in our body. If the motor cortex is affected means the patient may experience some kind of abnormal movements or general convulsion. So what a convulsion is? It is a medical condition where the body muscles contract and relaxes rapidly and repeatedly, resulting in uncontrolled shaking. If the motor cortex is affected, it affects the abnormal movements. And if the seizures is originating in the parietal or the occipital lobe, this includes it may affect the visual, auditory, and olfactory hallucination. This may result in these three characteristics. Next, going to the etiology. So, the causes for epilepsy includes intracerebral injuries, that is tumor or some conditions like stroke, metabolic disorders in our body, infections such as meningitis, viral encephalitis, measles, mumps. If the patient had any previous head injury such as falls or head trauma, birth injury means the brain injury which happens to the fetus during the pregnancy or the birth. And the next one is perinatal asphyxia. This is the lack of blood flow or gas exchange to or from the fetus in the period immediately before, during, or after birth process. Next is postnatal vascular accidents. Next one is fever. If we are having high fever means this can also be a main leading cause for epilepsy. If any medications is missed, that is anti-epileptic medications that is missed, or we have exposed to the flickering lights, stress, lack of sleep, alcohol intake, or if the patient has the hereditary familial history, inherited different degrees of susceptibility to the seizures, and also hypoglycemia, alteration in the blood gases, pH, electrolytes, and some kind of environmental factors also leads to epilepsy. Now, classification. We are moving to the classification of seizures. It is characterized by site of origin, etiology, electrophysiological correlation, and clinical presentation. The nomenclature developed by ILAE, that is International League Against Epilepsy, this is considered as a standard classification for seizures and epilepsy syndromes. Seizures are first categorized by the type of onset and have been classified into three broad groups, that is focal, generalized, and combined, and focal, generalized, and unknown category. So, looking into that figure, you can know that three main things we need to note it out. Like from where the seizure begins in the brain, the level of awareness, if the patient is aware or loss of consciousness is present or not, and the features of seizures. Mainly, it is divided into two: focal and generalized. Focal means the seizure starting from one side of the brain, and in case of generalized, the seizure starting is from both sides of the brain. In focal type of seizures, the level of awareness, the patient may be aware of the situation or they may be impaired of the awareness. And in generalized means it is the immediate loss of unconsciousness. And the features of the seizures includes motor and non-motor in focal and generalized motor and non-motor. The generalized non-motor is primarily absent seizures, and the other one, the focal, includes motor features of the seizures includes twitching, jerking, stiffening, and the non-motor includes changes in sensation, emotions, thinking, and experiences. If the seizure spreads to both sides, then it is referred to as focal to bilateral seizures. Now we'll move on in detail to each classification. First one is focal type of seizure. It is also known as partial seizure. It is most common in 80% of the people. It originates from one hemisphere of the brain and may originate in the subcortical structures of the brain. And it may progress to become the bilateral tonic-clonic seizures. In this case, the patient may lose consciousness or may be aware of the conditions or situations. A focal seizure can also be characterized by motor or non motor activity without specifying the level of awareness. Next, generalized seizures. So that we can see that the patient is having impairment of consciousness in this case. Immediate loss of consciousness may happen in this case. No doubt, may begin locally and then progress to both sides of the hemisphere. Primarily, the generalized seizures may be convulsive or non convulsive. Generalized onset seizures are divided into motor or non motor, that is, absent seizures. So, in detail, first one, tonic-clonic, which is also known as grand mal seizures. In this case, the patient may experience a sudden loss of consciousness followed by the tonic, that is, continuous contraction, and clonic, rapid contraction and relaxation phases. The tonic phase, the patient may become very rigid, which increases the muscle tone and falls to the ground, which lasts about 1 minute, that is less than 60 seconds. And in clonic phase means short episodes of muscle contraction, that is rapid muscle jerking. Muscle flaccidity, that is a kind of paralysis where the muscle becomes soft but not too firm, and the consciousness is more impaired. Next one is myoclonic. That is sudden involuntary jerking of facial limb or trunk muscles in rhythmic manner. It can occur at any age, usually begin around the puberty or early adulthood. The muscle contraction that lasts for several minutes. And the third one, atonic, means it is a drop attacks. Suddenly, the patient may lose the postural and muscle tone. Absence seizures. Next one. It is also known as petit mal seizures. The alterations of consciousness. That means the patient will be completely in absent state, which lasts up to 10 to 30 seconds. Onset gradually occurs in 3 to 5 years of age, and it may last until the puberty or beyond. I think we all may have seen some person staring continuously at one place. So, in this condition, similar to that, the patient stares and exhibit the rapid eye blinking, which lasts for about 3 to 5 seconds. They may stare at one position and they may exhibit the rapid eye blinking. And how will we diagnose this epilepsy? So, the epilepsy can be diagnosed by electroencephalogram, magnetic resonance image, the computerized tomography, blood test, lumbar puncture, genetical testing, and video EEG monitoring. This electroencephalogram measures the electrical activity in the brain. Moving on to the mechanism of the anti epileptic drugs. Seizure results from brain electrical disturbance balance. Brain is a complex of neurons which communicate through the neurotransmitter. A neuron can be both excitatory or inhibitory. Excitatory neurons stimulates others to fire the action potentials and release the neurotransmitter, whereas the inhibitory neuron suppresses this action. A balance between the excitation and inhibition is essential for normal brain functions. So, in epilepsy, there is an upregulation of excitation and downregulation of inhibition. This causes a lot of neurons to fire synchronously at same time. That means large number of neurons at same time. Basically, a neuron is more responsive when it is having more positive charges, and it is less responsible when it becomes negative. Typically, the excitation is mediated by sodium and calcium positive influx, while the inhibition is a result of chloride influx or the potassium outflux. And this anti-epileptic drugs aims to reduce the excitation either directly acting on the voltage ion gated ion channels or indirectly acting on the function of these neurotransmitters. So, the main excitatory neurotransmitter is glutamate and the inhibitory neurotransmitter is GABA. These anti-epileptic drugs inhibit the depolarization of neurons by following mechanisms. First one is inhibition of the excitatory neurotransmitter, that is glutamate transmission. And the second one is enhancement of inhibitory neurotransmission. So it decreases the excitation and increases the inhibitory action. Next one is blockage of voltage gated positive current, that is sodium and calcium. Several drugs blocks the sodium channels, which is essential for the depolarization phase of this action potentials. They selectively act on rapidly firing neurons and therefore is effective only when the neurons are hyper excited. And coming to the calcium channel blockers, they mainly act on T-type calcium channels. Mainly they act on T-type calcium channels, which opens in response to the small depolarization of plasma membrane, bringing the plasma membrane voltage closer to the threshold. They are concentrated in the dendrites of neurons and play an important role in the synaptic integration. Next one is increased outward positive current, and many anti-seizure drugs or anti-epileptic drugs act via more than one mechanisms. They act via multiple mechanisms. The anti-seizure medication suppresses the seizures, but they do not cure or prevent the epilepsy completely. Moving on to the anti-seizure medications like anti-epileptic drugs in detail. First one, it includes benzodiazepines. Always keep in mind that it is reserved for emergency or acute cases. The mechanism of how it works, like the mechanism of benzodiazepines. It gets bind to the GABA to its receptors, triggering an opening of the chloride channels, which leads to hyperpolarization of the cell. This benzodiazepines binds to GABA inhibitory receptors in order to reduce the firing rate of neurons because GABA is an inhibitory neurotransmitter. And this also increases the frequency. That is the main point. Increases the frequency of GABA mediated chloride channel openings. If it is given in pregnancy means it crosses the placenta and it may lead to CNS depression, that is CNS depression before the birth. And if used chronically, we may also develop tolerance. The clonazepam and clobazepam are the two group of drugs which is particularly used for the type of seizures. Clobazepam is metabolized by CYP3A4 and 2C19 metabolic pathway, and the active metabolite of the clobazam is norclobazam. And diazepam is also used for rectal and intranasal administration. in order to avoid the prolonged generalized tonic-clonic seizures or clusters. Next one, moving on to first generation anti-epileptic drugs. This mainly includes valproic acid, phenytoin, carbamazepine, ethosuximide, and phenobarbital and primidone. So, first one, valproic acid. Valproic acid is also known as valproate, which has a broad spectrum of activity. This is mainly used to treat the focal and generalized seizures. It has a broad spectrum of activity and used to treat both focal and generalized seizures. The mechanism of action includes sodium channel blockade and also the blockade of GABA transaminase, which inhibits the GABA degradation, which is enzyme which is responsible for the GABA degradation. And also it acts on T-type calcium channels. The valproic acid is available as a free acid and divalproics. It is a combination of the sodium valproate plus valproic acid. This converts into valproate when it reaches the GIT. This was developed in order to provide the GI in order to promote or improve the GI tolerance of the valproic acid. The initial dose of this drug is 10 to 15 mg per kg per day, and it can be increased by 5 to 10 mg per kg per week to achieve the optimal clinical response. Controlled release tablets can be given once daily. These drugs should be used in caution with hepatic insufficiency patients and can be avoided with patients with urea cycle disorders such as hyperammonia, increased concentration of ammonia in the body. Combining the drug or valproate with topiramate, there is another kind of anti-epileptic drugs, increases the levels of ammonia. It also causes acute hepatocellular injury with jaundice or acute pancreatitis, so that we have to monitor the liver enzymes frequently. If we are taking valproate, means we have to monitor this liver enzymes frequently. That includes LFT and all. The sodium valproate can inhibit the hepatic metabolic processes such as oxidation, epoxidation reaction, and conjugation. The side effect mainly includes dose-related tremors, weight gain that is due to appetite stimulation, thinning or loosening of hair, menstrual irregularities, this is amenorrhea, absence of menstruation, insulin resistance, and subclinical hypothyroidism. Looking into that figure which has been provided in the right side, we can see that the valproate side effects mainly includes vomiting, alopecia, that is thinning or loosening of hair, liver toxicity, pancreatitis or pancytopenia, retention of fat, that is because weight gain, edema, appetite increase, tremor, and enzyme inducer in liver. And the drug interactions of valproic acid includes with other anti-epileptic drugs, that is particularly with phenytoin, phenobarbital, and carbamazepine epoxide and lamotrigine. These drugs are inducers, so they have drug interactions, and this if combined with aspirin means it displaces the sodium valproate from its binding site on the plasma protein, and thus it inhibits the metabolism. And if used in women of childbearing potential, it may cause teratogenicity, which leads to potential teratogenic neurotoxicity. The second drug is phenytoin and fosphenytoin. Fosphenytoin is used for both focal and generalized, that is tonic-clonic seizures, and also it is used in the treatment of status epilepticus. The mechanism of action includes it blocks the voltage-gated sodium channels by selectively binding the channels in the inactive state, which leads to the prolongation of sodium channel inactivation. Fosphenytoin is a water-soluble phenytoin. It is used in acute situations when the phenytoin is contraindicated. In such conditions, the phenytoin can be used. It is a prodrug. And also it has advantage over the phenytoin because as it is a water soluble drug, it has the increased solubility, so it is the advantage over phenytoin. It is used in the treatment of status epilepticus, neurosurgery prophylaxis, and short-term oral phenytoin substitute. And this drug also has the off-label use, that is, it can be used in traumatic brain injury in order to prevent the post-traumatic seizures. This phenytoin induces CYP2C and 3YP3A families. Mainly, it induces these two families. And also, it exhibits a non-linear pharmacokinetic properties. That is, a small increase in the daily dose can produce a large increase in plasma concentration, which results in the drug-induced toxicity. High levels of phenytoin will be present in our body. So, what a non-linear pharmacokinetic properties is? This occurs when the body's processing of the drug is saturated at higher doses due to the limit of enzymes or the transported capacities. This causes the kinetic parameters like clearance or DHA to change with the dose. And in nonlinear pharmacokinetics, the rate of the drug administration, distribution, metabolism, excretion is directly proportional to the dose. The phenytoin has narrow therapeutic range, that is 10 to 20 mmol per liter. It has a narrow therapeutic range. The neurotoxicity symptoms includes drowsiness, dysarthria, that is difficulty in speaking, ataxia, cognitive difficulty. The toxicity should be made on clinical grounds. It should not be assumed with high levels of dosage. And in case of chronic toxicity, the permanent cerebellar damage occurs. And so that if the patient is taking phenytoin, means we need to monitor the phenytoin levels regularly. Fosphenytoin has no oral formulation. The common way in order to administer the fosphenytoin is IV, and IM is also available. But it is not recommended for the neonatal pediatric population. But the fosphenytoin gets converted into phenytoin within minutes with a ratio of 1:1 ratio with the help of an enzyme called phosphatase. This happens in liver and RBC, red blood cells. This fosphenytoin can be administered with both glucose and saline. This is an advantage, or this is a benefit comparing with phenytoin. Whereas this phenytoin cannot be given with both these drugs, like both these glucose and saline. And this phenytoin sodium is not given IM because it may lead to tissue damage and necrosis. The ADA profile of the fosphenytoin is similar to that of the phenytoin, and this happens more if we are administering through IV. Intravenous administration causes more ADR. The side effect profile includes at high plasma level or toxicity level, the dose-dependent CNS depression in cerebellum and vestibular system occurs. That leads to nystagmus and ataxia. That is, nystagmus is a vision condition in which the eyes make repetitive movements, and ataxia without coordination, or our coordination would be impaired. Next one is reversible cosmetic changes, which includes acne and hirsutism and facial coarsening. If long-term use of phenytoin, then it may lead to peripheral neuropathy, osteoporosis, gum hyperplasia, causes gum to grow over teeth, and the paroxysmal increase in seizure frequency with phenytoin toxicity. This fosphenytoin carries a black box warning. So sometimes they may ask, what is the black box warning for fosphenytoin? That is, it may lead to severe cardiac outcomes such as severe hypertension and cardiac arrhythmia. This is very important, that fosphenytoin is having a black box warning, which leads to severe cardiac outputs, that is severe hypertension and cardiac arrhythmia. Drug interactions. Moving to the drug interactions of phenytoin. This accelerates or increases the metabolism of lipid-soluble drugs such as carbamazepine, sodium valproate, ethosuximide, anticoagulants, steroids, and cyclosporin. So, um, in order to remind the side effect profile, this is very important. The main thing is hirsutism, gingival hyperplasia. This is the main areas of phenytoin you need to keep in mind. And first one, you can note it out: peripheral neuropathy, and H, hirsutism and hyperglycemia. E, enlarged gum. N, neuropathic disorder that is caused on long-term treatment. Y, yellow browning of the skin. T, teratogenicity. O, osteoporosis. I, interference of folate metabolism. And N, nystagmus. This is how you can remind the areas of phenytoin. The third drug is carbamazepine. The daily dose of this drug is 100 to 200 mg. Mechanism of the carbamazepine is this drug blocks the sodium channels and inhibit the generation of repetitive action potential in epileptic focus, and thus it prevents the spreading. It is used as the first line drug for focal seizure. So they may ask is which is the first line drug for focal seizure, and also it has uses in generalized tonic-clonic seizure, trigeminal neuralgia, and bipolar disorders. Oxcarbazepine. Usually the dose is 1200 to 2400 mg per day. This is the prodrug of carbamazepine, which is rapidly reduced to 10 monohydroxy metabolite MHD. This exhibits the anticonvulsant activity. Thus, it blocks the sodium channel and also it modulates the calcium channels. It is approved for the focal seizures in children and adults. It can also be useful as monotherapy or an add-on on management of other seizures. Carbazepine acetate. It exhibits the linear pharmacokinetics. As I have already said that in linear pharmacokinetics, the rate of the drug absorption, distribution, metabolism, and excretion is directly proportional to the dose. It is eliminated via glucuronidation, and the metabolic process is hydrolysis, and it gets converted into S-carbazine, the active metabolite of oxcarbazine. Voltage gated sodium channel blocker. It is also sodium channel blocker which is used for the focal seizures in adults. Now the main thing you need to keep in mind, or which is important, is carbamazepine is a strong inducer. It has auto-induction property. It induces its own metabolism, thus results in the low blood concentration at higher doses. Even if at the higher doses, they'll metabolize by themselves. Auto-induction process. So the blood concentration levels will be decreased after this auto-induction. And it is an inducer of CYP1A2, CYP3A, CYP2C, UGT enzymes, and it is not prescribed for absence seizures because it causes increase in seizures. And also, the next main thing about the carbamazepine is it also has an antidiuretic hormone like action. At high levels, this exerts an ADH like action. Thus, it results in the fluid retention in cardiac failure patients. The side effects is mainly due to the active epoxidate metabolite. This includes dizziness, diplopia, that is double vision, somnolence, that is excessive sleep, hyponatremia, rarely the skin severe eruptions, erythema multiforme, Steven-Johnson syndrome, reversible mild leukopenia, that is low WBC count, and rarely it may cause aplastic anemia or a granulocytosis, that is neutrophil count is less than 100 neutrophils per ml of the blood. In the drug interaction part of carbamazepine, first one, these drugs that there is two kind of interactions, like This drugs that inhibits the metabolism of carbamazepine that results in toxicity. This includes phenytoin, isoniazid, cimetidine, danazol, erythromycin, verapamil, diltiazem, etc. Whereas the drugs that induce the metabolism, that is auto-inducer, which decreases the levels in our body, that is oral contraceptive. If taken with oral contraceptive means this induces the metabolisms and the level of this drug will be decreased. Thus, it may result in contraceptive failure. Next is sodium valproate, antipsychotics, cyclosporine, sodium valproate, and corticosteroids. While taking carbamazepine, this decreases the thyroxine levels, increase the concentration of the sex hormone, and reduced testosterone in men. The fourth drug is phenobarbital and primidone. These are barbiturate class of drugs used for generalized and simple seizures, but it has addiction potential. That is, these drugs are scheduled 4 types of drugs. This has addiction potential and also as well as the sedating properties. The primidone is metabolized into 2 types like phenobarbital and phenyl ethyl malonamide. Phenyl ethyl malonamide. Sorry, I just mispronounced the word. So, in this case, the phenobarbital is the major one. It is used for both general and focal seizures. This phenobarbital can be used as the first line for generalized tonic-clonic seizures in developing countries, and it can also be used in status epileptics when the other agents fails to produce their effect. Anti-seizure properties and the sedative effects, these both properties have been seen in phenobarbital, and also this is useful in benzodiazepine and the alcohol withdrawal treatment. The mechanism of action includes the enhancement of this inhibitory effects of GABA. Like we know that GABA is the inhibitory neurotransmitter. So this enhances the inhibitory effects of GABA mediated neurons, and also it prolongs the GABA mediated chloride channel openings. Side effect profile which includes for this class of drugs are fatigue, listlessness, that is lacking energy or enthusiasm, tiredness, insomnia, hyperactivity, and aggression in children. The common side effects of these drugs is incoordination, impaired balance, agitation, somnolence, confusion, CNS depression, and drowsiness. If taken long termly, it may cause irritability, loss of appetite, achiness in the bones, joints, muscles, rarely liver damage. The drug interaction. As this is an enzyme inducer, this accelerates the metabolism of many kind of lipid soluble drugs. So what does it happen? It increases the metabolism, and so that the drug concentration or the level of the drug concentration will be decreased. If it was inhibitor means like it inhibits the metabolism of some kind of drug so that it increases the concentration. So here you need to keep in mind that it is enzyme inducer. Next one is ethosuximide. This ethosuximide inhibits the T-type calcium current channels in the thalamic neurons. This is mainly used in the treatment of absence seizures. So, if there is a question means what is the main drug or first line drug that is used in absence seizures means the answer is ethosuximide. This absence seizures, as we have discussed before, it occurs in patient over 3 years of age. This ethosuximide also has a narrow therapeutic index, but the bioavailability is 90%. It also has a long half-life and readily it may cross the blood-brain barrier. The dose adjustment is required if the patient creatinine level falls below the 10. So the creatinine clearance, you need to check like what is the normal creatinine clearance rate, or what is the normal WBC level, basic parameters, blood parameters, and clearance rate you need to keep in mind about this basic kind of normal levels of the sodium level, potassium level, chloride level, clearance rate, glomerular filtration rate, complete count, blood count, such things you need to keep in mind. Drug interactions. Next is drug interactions of ethosuximide. That this interacts with the drugs such as phenytoin, carbamazepine, and phenobarbital. You need to know that these drugs are potent inducers, which reduces the serum concentration by increasing the elimination. The side effects includes main common side effects are GIT effects, that is nausea, vomiting, diarrhea, and anorexia. Other kind of side effects includes drowsiness, lethargy, insomnia, hiccups, and headache. So you need to monitor the complete blood count and LFT. Severe rare blood dyskaryosis such as pancytopenia, leukopenia, agranulocytosis, there's decreased WBC, decreased RBC platelets. You need to monitor the complete blood count while taking this kind of drugs. And if the patient is contraindicated or patient is having hypersensitivity to succinamide, because this ethosuximide contains a structure of succinamides. So if the patient is hypersensitive to succinamides, then it is contraindicated in such patients. So these are all about the first line drugs of epilepsy. So from this portion, you need to note down which drugs is treated for which conditions, like, and in which all gated channels these drugs acts, like which drugs acts in sodium channel, which drugs acts in calcium channel, and which drugs acts with similar GABA action. Which drugs can be given with in both focal and generalized, which is only given for focal and which is only given for absence seizure. These are the things which you need to focus on from this medication part. Moving on to the second generation anti-epileptic drugs. The first one is levetiracetam. It is available as oral and both IV form. This is a pregnancy category C drug. That is, it can be given safely in pregnancy, but we need to monitor the serum concentration of this drug. This drugs also has a broad spectrum activity and can be given in adjunct therapy of the focal onset or myoclonic and primarily generalized tonic-clonic seizures. The mechanism of action of this drug is this binds to the synaptical vesicle protein SV2A. Binds to synaptical protein SV2A, which is found in neuron or endocrine cells. This may regulate the neurotransmitter release. Drug interaction is very minimal with this drug. So, and the side effect is behavioral disturbances, drowsiness, dizziness, upper respiratory infection. If the mood alterations, if you are observing any kind of mood alteration, you need to report, and the dose reduction or the change of medication is required in these conditions. Next is brivaracetam. That is a chemically derived analog or more potent than this leveracetam, and it is approved for add-on treatment for focal onset seizures. The oral forms is available in immediate release and extended release forms. The moderate inhibitor of epoxidase hydrolysis increase the levels of active metabolite of carbamazepine when given together. The side effect includes dizziness, tiredness, vertigo, headache, common cold, constipation, loss of balance, and coordination. The second drug from this second line drugs is felbamate. Felbamate is also having a broad spectrum of activity. So you can look on to page number 241. On the right side top corner, you can see which drugs has narrow spectrum activity and which of the drugs has broad spectrum activity. So you can just study that box, page number 241, figure 12.3. And in down portion, you can see the mechanism of anti-epileptic drugs. Okay. So, felbamate, it also has the broad spectrum activity, and this is reserved for the use in refractory seizures such as Lennox-Gastaut syndrome. This is a severe form. This Lennox, one second, okay. This is the Lennox-Gastaut syndrome is a severe form of epilepsy which is characterized by repeated seizures, continuous repeated seizures that begin early in life. This affected individuals may have multiple type of seizures or developmental delays, etc. That is, you need to keep, you need to uh, think like, remember that it is a repeated kind of seizures, continuous repeated kind of seizures, severe form. Severe form. The mechanism of action of this drug is this blocks the sodium channel competing with the glycine binding site on NMDA glutamate receptor. We know that glutamate is excitatory neurotransmitter, and also it blocks the calcium channels and potentiating GABA action. We told that while discussing the mechanism of anti-epileptic drugs, as we said, many drugs have more than one mechanism of action. So here you can see that they are having sodium channel blockade action, NMDA receptor action, competing for NMDA receptor action, blocking the calcium channels and potentiating the GABA action. So they have four mechanism of actions. So you just make a box and note it down which drugs has which mechanism of action. And the risk for aplastic developing this aplastic anemia is 1 is to 4,000, and hepatic failure and toxicity can also be seen with this class of drugs, so that it is contraindicated if the patient is having any kind of hepatic dysfunction or hepatic disease. Previously we have said one drug that is contraindicated, which leads to pancreatitis or hepatic injury with jaundice, so that is valproate, and here it is felbamate. uh, Dose dependent adjustment is required in hepatic, if given means the dose requirement adjustment is required in this hepatic disease or dysfunction. This drug is excreted via kidney, and also the dose adjustment in renal impairment patients or hemodialysis patients, in these both category also requirements these both category of people also require the dose adjustment. And the third one is gabapentin. Gabapentin is an analog of GABA. It also enhances or gets converted into GABA. So what is GABA? We have said that it is inhibitory neurotransmitter, right? It is also called as 4-amino butyrate amino transferase. This is approved as an adjunct therapy for focal seizures and post-herpetic neuralgia. That is, we some patients have get some patients have been affected with chickenpox, like varicella zoster virus. After this remains in dormant state. After many or few years, due to excessive stress, this inactive virus gets into active dormant state, which leads to the development of shingles. Shingles leads to post herpetic neuralgia, like we'll experience more kind of pain, neuralgic pain. So this drug is also approved for such kind of conditions, that is, post herpetic neuralgia caused by shingles from um, like mm, from the varicella zoster virus. This drug's similar to that of phenytoin also exhibits non-linear pharmacokinetics, and dose reduction is needed in renal diseases. So, in the mechanism of action, in the given structure, you can see that it binds to alpha 2 delta 1 subunit, and here it binds to the alpha 2 delta 1 subunit and gets into voltage gated calcium channels, binds to the voltage gated calcium channels alpha 2 delta 1 subunits, and thus this acts the block the action of the GABA. It binds to alpha 2 delta subunit of the voltage gated calcium channels, and thus it blocks the action. The side effect includes CNS related drowsiness, dizziness, diplopia, that is double vision, ataxia, headaches. And also, the main side effect is weight gain. At higher doses, the patient may experience weight gain with this kind of drugs. Occasionally, this may worsen the conditions of myoclonic seizures. Fourth drug under this category is lamotrigine. This drug blocks or acts by blocking the sodium channels and high voltage dependent calcium channels. They are metabolized primarily to 2N-glucuronide metabolite through UGT1A4 pathway. The use is focal, generalized, absence, Lennox-Gastaut syndrome, and can also be used in bipolar disorder. So, previously, one drug which we have discussed in the treatment of Lennox-Gastaut syndrome was felbamate. And see here, lamotrigine can also be used in similar conditions. The common side effects includes headaches, drowsiness, ataxia, diplopia, insomnia, nausea, and dizziness. Slow titration required when added with valproate because it increases the risk of rash, which leads to the progressing of the life-threatening reactions. The drug interaction with this category of drugs is it the levels can be increased by valproate, thus the dose should be reduced, decreased by carbamazepine, phenobarbital, and phenytoin. Next one is tiagabin. Tiagabin is can be sorry Tiagabin can be used as an adjunctive therapy in focal seizures. That is, it is not indicated in any other epilepsy. They are used as an adjunctive only in the focal seizures. They have no other uses. This blocks the GABA uptake into presynaptic neurons. Thus, blocking the GABA uptake into presynaptic neurons, this permits more amount of GABA in the synaptic cleft left for receptor binding. Thus, it enhances the inhibitory activity. Increased amount of GABA leads to inhibition. So here, the uptake of GABA uptake of the it blocks the uptake of GABA. Next one is topiramate. Topiramate, the use of this drug is both in focal and primarily generalized epilepsy, and the other use or the off-label use can be given for the prevention of migraine. The mechanism of this class of drugs is this class of drugs blocks the voltage dependent sodium channels, which reduces the high voltage calcium channel, that is L type. The rest of the drugs was of T type, and here they blocks the L type, and also note it down, it also has a carbonic anhydrase inhibitor activity and may act as a glutamate sites for NMDA receptors inhibitor. So they may ask like which drug is having carbonic anhydrase inhibitor activity. So that is topiramate. The side effect profile for this class of drugs is somnolence, that is excessive sleep, weight loss, and paresthesia. Renal stones, glaucoma conditions can also be seen, and hypothermia, increased temperature, can also be seen. Oligohydrosis is the decreased amount of sweat. Interactions. It mildly inhibits with CYP2C19, and if co-administration with phenytoin and carbamazepine, it reduces the serum concentration or levels of these drugs. Next one is pregabalin. The use is it is used for focal onset seizures, diabetic peripheral neuropathy. As like the gabapentin, it can be used in neuropathic pain, post-herpetic neuralgia, and fibromyalgia. It binds to the alpha 2 delta alpha 2 delta site of voltage gated calcium channel, similar to that of gabapentin. The mechanism is similar to that of gabapentin. It binds to alpha 2 delta 1 subunit site of voltage gated channels, and it inhibits the excitatory neurotransmitter release, that is glutamate. It inhibits the excitatory neurotransmitter release. Drug interactions is very minimal with pregabalin. The 90% of the drug is eliminated renally. The dose adjustment required in renal dysfunction patients. In case of gabapentin also, the dose adjustment was required in renal dysfunctions. Next one, moving on to vigabatrin. The mechanism of action of this class of drugs is the inhibitor of GABA transaminase, GABA T. That is, this enzyme helps to break down a brain chemical, that is GABA, when not required or when not needed, which is responsible for the metabolism of GABA, which inhibits the gamma degradation. So the area you can see VIGA, visual field defects. That is the main adverse effects of vigabatrin. VI for visual field defect, and GABA, GABA transaminase inhibitor, GABA TR, so GABA T, so you can remember easily. Then IN inhibition, GABA transaminase inhibition, and visual field defects is the main area. Next one is zonisamide. It also has the broad spectrum of action. This drug is a sulfonamide derivatives used in focal epilepsy. The mechanism of action of this drugs is blockade of both voltage gated sodium and T type channel currents and limited carbonic anhydrase activity. So there is two drugs that is having carbonic anhydrase activity. The side effect profiles includes CNS adverse effects, kidney stones, oligohydrosis, so that you should monitor for increased body temperature and decreased sweating. As they are sulfonamide derivative, if the patient is hypersensitive to this any kind of carbonic anhydrase or sulfonamide category, so in these conditions this drugs is contraindicated if the patient is hypersensitive to sulfonamides or carbonic anhydrase inhibitors. Next is third generation anti-epileptic drugs. First one, lacosamide. Lacosamide is used as an adjunctive treatment for the focal seizures. 50 mg, the dose is 50, it is available in 50 mg, 100 mg, 150, and 200 mg. Oral solution is also available for pediatric population. The oral solution will be 10 mg per ml, 200 ml bottle. This drug is also pregnancy safe category C kind of drug. Which was the other one that was pregnancy C category of drugs? Levocetran. Okay. The mechanism of action. Unlike the other drugs, this enhances the slow inactivation. This enhances the slow inactivation. Once again. Sorry. It enhances the slow inactivation of voltage gated sodium channels, which results in the stabilization of hyperexcitable neuronal membranes, and thus it inhibits the repetitive neuronal firings. And this may also interact with collapsin response mediated protein 2, that is CRMP. This also interacts with this protein and thus inhibits the neuronal firing, which is this CRMP2 is involved in the neuronal differentiation and the control of axonal outgrowth. The common side effects includes dizziness, headache and fatigue. Next class of drugs is perampanel. Perampanel, the precise mechanism of this drug is unknown, but still they are like the mechanism that they are proposing is that AMPA type glutamate receptor antagonist. That is, this AMPA receptors are glutamate gated ion channels. Glutamate means excitatory. Glutamate gated ion channels present in wide range of neuron types and in glial cells in the brain. Their main role is to mediate the fast excitatory synaptic transmission, and therefore they are critical for the normal brain functions. So, in this case, this perampanel shows the antagonistic activity that selectively targets this neuroexcitatory pathways and inhibits the seizure activity by reducing the overstimulation of this AMPA receptor, AMPA glutated gated channel. Glutated, sorry, not glutated, it's glutamate gated ion channels. Thus, it decreases the excitation by non-competitive inhibition of this non-competitive inhibition of the AMPA receptor. The use of this drug is adjunctive treatment of the focal and generalized tonic-clonic seizures. This drug also has a warning. This may lead to serious psychiatric behavioral reactions, including aggression, anger, irritability, and homicidal ideation. So, uh, the second drug, like we were discussing about the phenytoin and fosphenytoin. So, there I have told you that the fosphenytoin is having a black box warning, which leads to severe cardiac outputs, such outcomes such as hypotension. So, that is also an important thing. Here, this perampanel is having a warning which leads to serious psychiatric and behavioral reactions, that is aggression, anger, irritability, and homicidal ideation. This is also very important. Next one is rufinamide. The use of this drugs is adjunctive treatment of seizures that is associated with Lennox-Gastaut syndrome, children over 4 years and adults. We have already discussed what Lennox-Gastaut syndromes, that is severe form of epilepsy which has a repeated or continuous seizure syndrome. Drug interaction. This drug is a weak inhibitor of CYP2E1 and weak inducer of CYP3A4 enzymes. So thus it interacts with these class of drugs. And also the food increases the absorption and the peak serum concentration. If given with carbamazepine and phenytoin, if the combination with carbamazepine and phenytoin is given, it reduces the levels of this drug, and if given with valproate means this increases the concentration. Why? Because these are inducers and this is inhibitor. So, if combined with these two inducers, the level or concentration will be reduced, and if it's given with inhibitor, means the concentration will be increased. And the ADR, it has a potential for shortened QT interval. In our ECG PQRST interval, the QT intervals will be shortened, so that we should avoid in patients with having previous familial history of short Q3 syndrome. That patients is contraindicated. We should avoid in such patients. The fourth one is stiripendol. That is, the use of this drug is only limited to Dravet syndrome. This drug is only given for the Dravet syndrome. That's a severe form of myoclonic seizures. If this drug is taken with clobazam, this increases the concentration of both clobazam and their active metabolite, which is norclobazam. The mechanism of action is this also regulates or modulates the GABA receptors. So, thus, it has an inhibitory action. Moving on to the main category, status epileptics. What is status epileptics? This is defined as more than 30 minutes of continuous seizure activity. The continuous activity of seizure more than 30 minutes, or the recurrent seizure activity without an intervening period of consciousness. Two or more seizures without recovery of full consciousness in between the people, then it is known as status epileptics. So, this can be both focal or generalized, convulsive or non convulsive. This is a life threatening condition and it requires the medical emergency with parenteral administration of the drugs of fast acting medications such as benzodiazepines, followed by then short acting medications. So, in the emergency conditions, we should administer the parenteral route with fast acting benzodiazepine in first, and then move on to second category, that is slow acting medications such as phenytoin, fosphenytoin and divalproex. So, the first line drugs for status epileptics is benzodiazepines. The common cause for such a status epileptic condition is missed medications of anti-epileptics, the metabolic disturbances, some kind of metabolic disturbances in our body, if there is any CNS infection or head trauma and hypoxia, decreased amount of oxygen in our body. So the treatment part for this kind of epilepsies is first line includes benzodiazepines. Major drugs is benzodiazepines, that includes lorazepam, diazepam and midazolam. The dose for lorazepam is 2 to 4 mg IV and the diazepam is 5 to 10 mg IV. Third one is midazolam, 2 to 4 mg IV. Second line category for the treatment of status epileptics includes, as we said, slow acting medications, that is phenytoin or fosphenytoin, valproic acid, phenobarbital and levetiracetam. And the third line drugs include pentobarbital and propofol. These are the category of treatment plan for the conditions such as status epileptics. So, just brushing up about the anti-epileptic drugs. So first one, it has an action of sodium channel blockers, binds to inactive sodium channel and it extends the inactivation. In case of phenytoin, sodium channel blocker and complex actions. If it's case of lamotrigine, sodium channel blocker, selective for excitatory neurons and glutamate. If it's ethosuximide, calcium channel blockers, alpha subunit, T-type and in thalamic neurons. Phenobarbital is gamma antagonist. Valproate has many actions, that is, it blocks sodium channel, enhances the GABA and blocks the calcium. So you need to make a box or you need to classify according to their mechanism of action, according to their uses and their interactions pathway. So it will be very helpful. Otherwise, like, it will be very difficult for us to remember like which drugs is used for which conditions, because many of the drugs has both actions, like for focal and generalized. Some drugs only has an actions for focal, some drugs only acts for has actions for absence. So it's better to classify according, or you need to provide notes according to the mechanism and their uses. So this is all about anti-epileptics or epilepsy. So, if you have any doubt regarding this topic, you can contact the faculties at any time. We'll clear it off. So, that's about this topic. I hope you guys are clear with this. Okay, thank you.